as the hour goes. So thanks for coming to PICU Educational Rounds. And I will be happy to answer questions at the end, and you can put them in the chat. We're also a fairly small group, so I'm open if you want to try to raise your hand during this talk. I'll try to keep track of that as well, so that we can answer some questions. Today, my topic is the bedside pediatric early warning system, which is a big new initiative that's coming to our program. Before we begin, I'll just do a land acknowledgement, acknowledging that the University of Manitoba is on the traditional lands of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and on the homeland of the Métis Nation. We respect the treaties that were made on these territories. We acknowledge the harms and mistakes of the past, and we dedicate ourselves to move forward in partnership with Indigenous communities in a spirit of reconciliation. I also am coming at you today from the University of Toronto lands, where I'm in Toronto. So I will also acknowledge that for thousands of years, this, where I am today, was the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. In terms of things that I would hope we could all reflect on for this talk is many of our patients are not from Winnipeg. They come from very big distances. My hope, and I'll talk a bit about this at the end, one of the reasons I'm so passionate about this early warning system is the hope and plans to eventually put this across the entire province of Manitoba, where we can better identify children who need to come to us sooner and hopefully improve their trajectories sooner and in a faster kind of timeline. So with that, I will bring the objectives for today. So firstly, we're going to review what PEWS, so Pediatric Early Warning System. I'm just going to call it PEWS for the rest of the talk. I'm going to talk about the scientific evidence for its use and background. I'm going to review the plans that we're doing here in Winnipeg. And then at the end part of my talk, we're going to explore specifically in the context of our PICU and the PICU response to a pediatric early warning system. So to start with, what is PEWS? So to reflect on that, let's think of three examples of, oh, I keep freezing for a reason. Okay. Sorry, can you guys, I'm on Wi-Fi. Let me just see. Is everybody experiencing me freezing? Oh, okay. Let me see. I could try to go on a different way. Okay, I am on Wi-Fi, so hopefully it works, but please just tell me if I freeze again, and I can try to do it through my phone. Okay. All right. I'll keep an eye on the chat. So I guess just to begin with then, think of these three scenarios, which did all occur to me when I was in training, and how we respond to them. These are three kinds of scenarios that you might interpret and how we escalate care. So firstly, I got a page when I was in training at 3 a.m, asking me if it was necessary to keep doing daily weights on my patient. And if you were to categorize this, most of you would probably think that this is a non-urgent issue and you could deal with it later in a safe manner. In the same way, when I was a first-year resident, I was taking care of a patient and screening them for psychosocial challenges, and they suddenly stopped breathing because they had taken an overdose. And in that case, it was also pretty obvious what to do, that this is an emergent situation, and we called the code blue and got help arriving right away. This next patient, though, is one that is more common, which would be like our typical bronchiolitis patient, who our patient hasn't responded to initial therapy. She's clinically worse than before, but not an imminent respiratory failure, so still breathing. And it's pretty difficult to classify these situations It's often the more common situation, and it can be more challenging to classify, especially when you have less experience. So you may classify it as urgent, but what does that mean, and how fast do you escalate care for these patients, and what do you actually do? So classifying patient clinical situations can be challenging. Myself and some of my other colleagues took some time. It took us about 2 years where we wrote up a document about our actual process in the hospital right now for escalating care. And we did try to classify situations as being non-urgent, implying that the patient is stable condition. Urgent implies that the patient is unstable or at risk of becoming unstable, but doesn't need immediate intervention, or emergent, where it implies that the patient is unstable and needs immediate intervention. These, however, how you classify them can be very subjective and based on the opinion of those involved in looking at the patient. We also have, as a learning hospital, a learning ladder where you have junior learners, and this would be in all different categories of healthcare providers. So junior learner in physician, medical student, all the way up to most responsible physician. But you could similarly think about a new nurse who's just arrived to work in our center, all the way up to somebody who's worked there for 20 years and has a ton of experience. The knowledge and responsibility does go up the ladder, but we have to work within this situation, or within this context of always having learners and people trying to classify patients. Within all of this, the thing that we really want to prevent and are always worried about is arrest, and trying to prevent that, because we do know that it's a big challenge and it has a lot of risks associated with it. So cardiovascular and other comorbidities. And so if we are thinking of this as being a big it that we're trying to prevent, cardiovascular collapse and cardiac arrest is very rare, but there is still a pretty high chance of death if you arrest, even while in hospital. So, excuse me, this is a bit of older data, but you can have a range in your hospital populations between 0.1 to 20 per 1,000 children who may have cardiac arrest. And this will depend, again, on your patient population as well. So cardiac centers may have higher versus outpatient, or sorry, not outpatient, but lower level tertiary centers may not. Most of the arrests already occur to patients who are already admitted to a pediatric ICU in developed countries, and 34 to 46% survive to hospital discharge. This is always a different range of survival, and it is improving, but it's still a pretty high mortality for when you have a cardiac arrest. In the past, and how we resuscitate children has also been changing with time. In the past, it was actually considered futile to resuscitate children who had arrest out of hospital, so cardiac arrest, if the arrest was longer than 20 minutes or they've received greater than 2 doses of epinephrine. We now know that we can have fairly good outcomes, even if you've done for more than 30 minutes, and that's why most of us will do CPR for a lot longer in hospital, especially if it's witnessed, and also give more than 2 doses of epinephrine. Within the patients who do have cardiac arrest, you will have still neurologic sequelae is still very common. So meaning they may have developmental challenges after the arrest, because you can have associated neurologic or other organ injury. And ultimately, cardiac arrest is not one single entity. It's actually multiple different pathways to get there. Most commonly would be respiratory arrest that then causes cardiac arrest. But there's not one treatment that will get rid of all arrest, is kind of my point with that statement, that it's caused from different things. And the only way you can really identify it is trying to look at early identifiers for every single kind of clinical deterioration. With all of that, we have another challenge. So firstly, we're trying to prevent cardiac arrest. We're also trying to prevent clinical deterioration, which ultimately could lead to arrest. And within all of that, we also have kind of variable definitions of what would require higher levels of care. So this is the part that we're trying to prevent. But then we also have on the flip side of trying to understand who ends up needing a critical care bed, who needs higher level of intense care, who are the ones that we need to watch more closely and take care of them. And the definition of critical illness is maybe unsurprising to this group, is not really well defined. But often proxies for critical illness end up being admitted to an ICU, which is a circular definition. There are things like critical illness insurance that tries to define it, but it's very specific and can't really be applied to patient populations in hospital. And then there's also definitions. This one I took from Wikipedia, but it's very similar to the Royal College or American Academy of Pediatric definitions, where intensive care or critical care is a branch of medicine concerned with the diagnosis and management of life-threatening conditions that may require sophisticated organ support and invasive monitoring. So really, if you read that, it's pretty hard to say you could define an exact population that needs critical care or intensive care or high level of monitoring. So critical illness also is defined by the technology that you may need. But again, this is evolving constantly. And most people on here would recognize that it's shifted a lot in our hospital. For example, it's not even been, I think it's only been about 2 years where we've had high flow nasal cannula on our general wards, and the level of care and things that our patient needs is constantly evolving, and the higher level of care needs for our patient population on the wards is certainly recognized. And then there's also the idea overall. Okay, I don't know why it keeps freezing. I'm sorry. I can try coming to a different. Okay, I'll just stop share for a second and then try going on different Wi-Fi. Okay, we'll try on this Wi-Fi. I hope that it works okay. Uh, okay. Can you guys hear me at the moment? Oh, okay. I'll turn off my camera too. That's a good thought. Okay. Yeah, I'm on the bandwidth at like a personal home, so it usually should be okay. But now I went on to the one on my phone, so hopefully it's okay. Can you guys hear me at the moment? Much better? Okay. Okay, sorry about that. Okay, so my last point about critical illness is sometimes it ends up being this feeling that it's like I'm not comfortable with this patient, but that's kind of the most difficult one to define. And but it's one that we often hear from frontline staff is just I'm not comfortable. But does that necessarily mean they need to come to an intensive care unit, or does that mean what is it that they actually need to care for these patients? In trying to predict the patient population that might need higher level of care, unfortunately, there really is no gold standard to define acuity, as mentioned. I've researched that many times and keep looking for it. But again, it's really difficult to define this specific population. And worldwide, hospitalization and admission to PICU are proxy for severity of illness in the emergency department or other places where they're trying to define acuity, which, as mentioned, kind of makes it this circular definition where you're having a proxy of saying that they're critically ill because they're admitted to an intensive care unit. So that also makes it very challenging to define. So in order to try and kind of fill in this gap and get the care to patients who need it the most fastest, this is where pediatric early warning systems have come in. The first PEWS was actually published in the UK in 2005. So they've been around for almost 20 years by this point. By 2013, 85% of all UK pediatric hospitals were already using a PEWS. And if you look in the literature, at least as of 2018, when I last did a full literature review, there's at least 21 different published PEWS. PEWS is different from a trigger tool. So they actually make score match recommendations, meaning you don't have to do exactly what it says. It just recommends that you consider this pathway, which differs from a trigger tool. So if any of you have ever seen or worked with those, trigger tools mandate an action based on a score. There's multiple PEWS, as I mentioned, that have been published, and there's been multiple systematic or a few systematic reviews on them as well, and they can be kind of categorized as this group of systems that try to find children who have clinical signs of deterioration before the actual deterioration, and try to help clinicians and bedside clinicians recognize the signs of worsening. So if you look at this PEWS concept, which is the kind of graphical figure here, it has time and severity of illness, and then you have 3 patients. So patient A gets better when they come into hospital with just kind of routine care needs. Patient B, however, you can see is their severity of illness is increasing, and the aim is to identify this and intervene so they become patient B, carrying on, rather than a third patient who carries on worsening and ultimately has an arrest or death. The one that we're going with after an extensive review of the literature is called bedside PEWS. So you'll see B PEWS in front of it. And after multiple reviews, this is the one that is the best studied in the world. It's the only one that's had an international randomized control trial. It's used in hospitals as far as New Zealand, in low-income countries like Guatemala, also in Italy, the UK, and the majority of centers in Canada that have PEWS are also using bedside PEWS. These 2 graphs show, firstly, the sensitivity and specificity. Graph, the area under the receiver curve, is you want it to be closer to like 0.8 or so to have a good intervention, and that's what we see is around 0.85, I think, for this, and it basically differentiates sick patients versus well patients very well. And the second part of the graph just shows that, or second figure shows that the score of your bedside PEWS will increase multiple hours before the event. There's some retrospective studies that show it could predict the event up to 36 hours prior to it. However, in clinical practical reality, it should usually show most clinical deterioration up to an hour before. There will always be patients that won't fit these categories, who suddenly have who suddenly have clinical changes that wouldn't be captured, or similarly, whose score remains very low but is very sick. So this, however, for the majority of patients, will differentiate between them being sick or well. The large randomized control trial that occurred and was published in 2018 looked at patients across the world. It was in the Journal of American Medical Association, and this was where they compared hospitals across the world that use bedside PEWS versus using regular vital sign acquisition. The primary outcome for the study was to look at mortality. So they based their power calculation on a presumed death incident rate of 5.1 per 1,000 hospital discharges, and we're hoping to reduce it by 1, with a secondary outcome looking at clinical deterioration event as a composite outcome. 10 centers were randomized to bedside PEWS, and 11 had usual care. And this study occurred from 2011 to 2015. There was multiple patients within it, so greater than 14,000 patient hospital discharges with greater than 55,000 patient days that were included in the study. And there were hospitals, all as mentioned, across the world in this study, although all in what would be considered developed countries. But it did include Canada, Netherlands, New Zealand, Ireland, Italy, and Belgium and England. So in reviewing this study, it did not show a decrease in hospital mortality. Unfortunately, there was no difference really statistically between. However, they actually had very low death rates in all studies. So the death rate was way lower than what they predicted. It was just 1.9 to 1.56 per 1,000 patient discharge. So likely it was too small of a patient population to tell the difference between them. And in pediatrics, mortality is never a very good primary outcome. However, in order to get the study funded and done, that was why they chose that as the outcome. But unfortunately, it didn't show the difference we were hoping for. What it did show, however, was that the clinical deterioration events were less in the bedside PEWS hospital versus usual care. And it did seem overall that the patients who needed to go to the ICU did get there sooner. So overall, the conclusions was that it did not reduce mortality, but as mentioned, there was low mortality in the study and not the best primary outcome. And late admission to PICU was reduced in the bedside PEWS group, which is a really meaningful outcome, in my opinion. The study also didn't assess the complex social system of hospitals involved and didn't really focus on communication benefits, which I would argue is one of the biggest benefits of bedside PEWS. Internationally, after this study came out, PALS, the Pediatric Advanced Life Support, did say that they couldn't recommend or couldn't make a firm recommendation to use it, but that they should do a systematic review. The political reason really behind this would be that PALS is international and not every hospital has the ability to implement something like this. And if they make it a strong recommendation, it would be a challenge for any hospital to meet their recommendation. However, since 2015, PALS and international guidelines have recommended that that you consider using PEWS in your hospital. And then another final big point, PEWS was developed, the bedside PEWS specifically, because I know the creators quite well. They developed it by looking at nurses who work in critical care and getting them involved and talking to them and looking at what they saw for clinical deterioration and kind of back engineering it and finding what score worked best and validating it. And they've done multiple studies that show that nurses really love using this tool because it's really a score that's integrated with the clinical judgment and works well as a combined entity. Not that the score or the clinical judgment supersedes each other, they work together. Although clinical concern always, if you have it beyond the score, you should always follow that. But it does help nurses advocate with a common language for when they're concerned and gives a quantified number to something that can sometimes be that gut feeling that's hard to communicate sometimes. And it overall improves communication throughout the team. So I'll now move on to what the Winnipeg PEWS plan is. When I first started this project, I developed a lot of ideas, and I'm just showing this slide because I would like to show even how much difference has changed since I started this project. So this hasn't changed. We are a tertiary care center in Manitoba, and we care for Nunavut, Northwestern Ontario, and sometimes Eastern Saskatchewan. In 2016 to 2017, we had around 7,000 admissions with around 25,000 patient days. And our bed capacity was around 100 for the general hospital. And acute care, we had 10 beds up to 13 in surge. And we had around 250 registered nurses, And this also has not changed, but mixed paper and electronic vital sign acquisition still occurs now in our hospital, for the most part being paper and then electronic in our emergency department. There's multiple different paper-based vital signs, and manual assessment and trends can be very difficult to follow. There's no robust database. This is to demonstrate, as you all recognize, there's been so much changes even since 2017, since coming here to all of this. Most recognizable, the patient population has really increased, and our acute care beds has basically doubled since this time. This slide will also just demonstrate the death or mortality rate. This has not really changed. I know that this is from 2017, but my recent talks and presentations, the mortality rate is still very similar across the country. We are still in Manitoba, our mortality rate 8.4 per thousand is above the Canadian average of 5.2 per thousand, and Nunavut is above even that, which is 13.3 per thousand. So this just demonstrates that we have quite a vulnerable population. And in terms of region, the child mortality, the statistic here, just to point out, is different. This is per 100,000, but our mortality rate is even quite different depending on where you're from within our different health regions, with the Northern Health Region being the highest and Winnipeg actually being our lowest child mortality. My initial project timeline when I first moved here is I thought I would have this rolled out by 2019, which did not occur. For multiple reasons. So this is the actual true timeline of this project. When I started here in Winnipeg in 2017, the project was already the thing I wanted to come back and do when I got here, and multiple critical incidents in the past supported this recommendation and was sponsored by leadership. I did a literature review in 2018, but the randomized controlled trial I just presented initially put a pause to the project because there was concerns from leadership that if it didn't reduce mortality, it may not be beneficial. However, after multiple discussions, we are kind of back on track for having this project. In 2019, I finished my master's degree in healthcare quality and did grand rounds on this topic as we built the project. And then 2020, unsurprisingly, COVID halted a lot of the plans, but we did work on a briefing note to get it funded, and then did a call to industry, and then we're able to see that bedside PEWS was the one we were able to go with. And in 2022, we finished our kind of current state, how we do it here to better be able to make the change, and made a core committee, and then work started in the past 2 years to finalize the plans, and we're planning to implement within about a month. In terms of the escalation protocol, so this is a current state protocol. Most of you would have seen this already, but this just demonstrates how people call for help right now in our hospital, which differs between day and night, and also reflects the learning ladder. This would classify for urgent and non-urgent, and emergent would follow our code blue, medical 25, and code 25 pathways. This would be for an inpatient. However, for something like the Children's Emergency Department, it's much more complicated, and we did it more in the swim lane diagram just because it depends on who they're admitted under. But just to give people an idea of how complicated things can be for people to figure out who they should call to get help. So with that, I made multiple mental models, or I guess physical models on the computer, of how we could visualize this project for our hospital. So overall, in the purple in the bottom is what I would say is the bedrock that we're trying to really solidify of a culture of safety in our hospital. And within that, we're integrating the pediatric early warning system. It doesn't change some of the other things like sepsis or other screening that might alert you to other concerns for a patient. And the other processes are still the same, like calling for help, but it's putting it all in a more directed system that's going to be more standardized and that helps people figure out who they can go to in a faster way. This is just another way to visualize the whole project. So we have an afferent system, which would be now, in the past would be our vital signs acquisition. And I should say right now too, because that's still how it is, that the bedside PEWS is going to replace that. And then we have within that who you escalate to and still some screening tools. You have your clinical deterioration, and then you have your efferent system, sorry, which would be clinician assessments, rapid response team, medical 25, and code blue. I'll go through these process improvement, but these are all the ways that we're going to be monitoring what's happening with the bedside PEWS and how we already look at things. So I'll go through them in more detail in a few slides. This is the team that I started with, and I just wanted to point out that from the beginning of our team, we've had physicians, residents on the team, health information administrator, respiratory therapists, managers, and educators, as well as quality consultants. I also wanted to point out that within the past 2 years of making this, almost every role has changed of the people who are in it at least 2 to 3 times. So that has been one of the challenges in getting things done quickly. But on the flip side, has added a lot of really great insight from multiple different people looking at it. We've had approval and support from multiple people, including our Director of Patient Care, Kate Witten, from our department head, Dr. Burke, HSC Executive, Patient Safety Office, multiple past iterations of leadership, and Forms Committee has been worked with as well. So what is bedside PEWS specifically? I've given you a theory. What it actually is an age-matched amalgamated vital sign and other signs, clinical signs. It's put into a validated scores with score match care recommendations. It's not validated in intensive care settings at this time, so we're not using it in the PICU or NICU. It's also not going to be used in our outpatient groups, which I'll specify in a moment. It enhances but does not replace clinical judgment. It replaces all the vital sign records, and it includes score match care recommendations. That includes frequency of vital signs, time to notify first medical review, time to notify most responsible physician, and recommends number of similar patients cared for by the same nurse. These are some narratives that come from frontline staff from Toronto that we've been using in our teaching. Just the frontline senses of being worried about patients. So felt something was wrong, but couldn't put my finger on it. Worried that the fellow, or resident, was not responsive to my concerns. Senior nurse did not approve of paging for extra help, or senior nurse called senior resident and stayed with patient till transfer. So lots of different approaches to patients who are potentially clinically deteriorating. From our own frontline, Dr. Najjar, one of the 4th-year pediatric residents, and I are just finishing our narrative review, qualitative review of the survey that we did, and maybe some of you participated in, around our own experience with escalation of care and communication in our hospital. While I can't give specific quotes at this time because we're just finalizing that, the overall was very similar, and many people said that the response depends on who the staff is that's working, and that can include PICU response staff. It includes the PICU intensivist, includes the hospitalist, includes anyone that's working, that they felt it depended on who was there, what their response would be, and that many people feel that their concerns were dismissed when raised. So the goals of bedside PEWS are then to create a common shared language around patient vulnerability, guides utilization of resources, encourages best practice, will trend the changes over time, and supports critical thinking and problem identification. And really is a systems solution to what is often a systems issue. So this is just Reason's famous Swiss cheese model, where usually there's multiple different things that line up where potentially a clinically deteriorating child is missed. So in Winnipeg, we identified at least 26 different paper forms found in our program where vital signs are recorded, ordered, or otherwise written, and we amalgamated all we could. We've made multiple drafts and reviewed and revised with core committee, and then also put call out to the entire hospital to try and get more feedback on it. Initially, and some hospitals include their fluid fluid intake output on PEWS forms, but we decided to make this separate. Sorry, and there will be a standardized fluid sheet that will come as future work. At this time, order forms where vital signs are ordered. We're not changing all the order forms at the moment, but as each one comes up for review, we're going to change them to say vitals as per PEWS. And we've also made these bright yellow stickers to be placed over things so that people know that it should be ordered as per PEWS. Vitals as per PEWS, what does that mean? It means routine vital signs is still Q4 hours unless otherwise ordered, and escalation of vital signs acquisition will always be as per bedside PEWS. So even if your child was on Q shift vital signs, because that's what their baseline needs dictated, as soon as they fall within a PEWS category, you would shift to what the PEWS recommendations are. The forms that we're going to be replacing are all of these. And I just took off the transfer of accountability because we actually are removing that from PEWS at this point. But it will be replacing multiple others. Of note, also the vital signs record. And this is what the form actually will look like. It's actually quite a large paper. So it's going to be almost like 3 pieces of paper, slightly larger, that fold together into one. And all this would be the front of it. All of the colors, so the correspond to the PEWS score. So all of the colored areas correspond to the PEWS score. And each color corresponds with a specific score and provides you with the score at the bottom. You calculate the score at the bottom, and then there's recommended actions to take depending on the score. And then also we've integrated all of the other things that are that nurses are recording on the general medical wards. The back of the form, the blue box is just where the transfer of accountability was. So we're just going to be doing one final draft, unlikely to include a little bit more note space, but it will have all of the nursing care assessment. The PICU here will recognize a lot of it because it's more similar to what we do in the PICU. But this is where all the systems review will also be written on here. So for an example, this is an example of a 15-year-old who was admitted with increased work of breathing and had oxygen requirements secondary to suspected lower respiratory tract infection. She had bilateral infiltrates. She's put on oral antibiotics and seems to be improving as she can walk around and she's able to talk in full sentences and is eating on her own. She was weaned off oxygen and you're planning to discharge her home. So over the night, more vital signs are acquired. I base this off of many patients we have actually seen. And 15, our teenagers are typically the ones we don't often see the trends as easily because their work of breathing is very different than our common patient, which is babies. More typically babies. So typically vital signs on a vital sign record would be charted in this manner in a kind of box form where it's actually quite difficult to see the trends and recognize them for worsening because you're just looking at numbers. It can be just on my own review of multiple past charts, it's very difficult to follow them. And often this kind of vital sign charting, I would say, is directly one of the causes for not recognizing the changes. So when you switch to charting in bedside PEWS, Now you can actually see the trend that they're increasing in many of the areas and that you're changing into higher risk categories. So when you score a patient, at first the score was 1, which would be considered just routine care. But her score actually goes all the way up to 7, which would be higher consideration to follow up, because at this point, she actually does have quite a high respiratory rate. And it would be a sign that maybe she needs a little bit more support. She's desaturating more. Maybe she actually needs a reassessment. Maybe she does need oxygen for longer. It doesn't tell you what to do, but just that she should be assessed more frequently. So bedside PEWS includes 7 critical indicators. It includes the documentation phase, calculating the score, and then score match care recommendations. The 7 critical indicators are heart rate, respiratory rate, systolic blood pressure, oxygen sat, oxygen therapy, respiratory effort, and capillary refill. The vital signs still need to be interpreted in the context of the child's condition, and normal vital signs are not always appropriate when a child is sick, as we all know. So this helps us, or it really highlights the fact that it's both together. So you could have a score of 1 and still call for help because you're still worried about a patient, or you could have a score of 12, which is one of the higher score, and not need immediate assistance because it depends on the patient. So many commonly asked questions is what about temperature, diastolic blood pressure, or level of consciousness? In all of the reviews and validation, these ones didn't separate critically ill, or sorry, well from ill, as well as the others, but they're still important. So they're still on here and you still take them into consideration. They're just not predictive of the evolving illness. And I think often because some of these are later findings, or contribute to the findings that you have. So they're just not part of the score. This is what the scoring kind of would look like. And sorry, and the score part is what I meant to say is white is 0, 1 is yellow, 2 is orange, and 4 is red. The score match care recommendations include the vital sign assessment frequency, senior nurse review, medical review, type of monitoring, consideration of expert consultation, and similar patients cared for by nurse. Initial review means once you first got the score. So if the score is 3 to 4, your initial, you follow up vital signs into every 2 to 4 hours, and you review within 8 hours. But and so if within that, if the next time you get the same score, so it's still 3 to 4, then you just continue on with the same review. However, some of them may suggest less frequent, depending on the score. The types of review for our hospital: senior nurse refers to the charge nurse, clinical resource nurse, clinical nurse specialist, or other nursing leadership within site policy. And sorry, within the site policy is because eventually we're going to be making this provincial. So that's why that language is in there. Also, primary medical review is any medical trainee, or nurse practitioner or fellow or physician assistant. And secondary medical review is always the most responsible physician or another staff physician delegate, but cannot be a trainee. The expert consultation includes our rapid response team, code team, code blue, or transfer to a higher acuity unit or monitoring. And similar patients cared for by the nurse doesn't mean that they won't care for multiple other patients. It's just that you wouldn't want them to be caring for like multiple patients with similarly high scores. So it will just be a tool to help us assign or help us put the resources better to where they may be needed. So PEWS, this is just some of the positive feedback that has been gathered over time. It pulls multiple concerns into one number, helps staff pull together and quantify the gut feeling, gives nurses permission to speak up sooner than they might otherwise, and empowers staff at the bedside to make requests for physician assessment and intervention and common language to communicate concerns. We have been teaching the front line already since October 16th. I'm not going to go specifically into this, but there will be videos of me going through it that you can watch to learn how to do it more specifically. But there is 5 different age ranges because of the different vital sign changes as children change their age. And respiratory effort is based on bedside PEWS language because that is validated. However, what we've been saying is if they're not sure, they can score at the higher level because some of it is subjective for, all the way up to severe. This is a bit of a more in-depth example. So I have a patient, Sven. This is one of the ones we're using for clinical teaching. He's trach and vent dependent and has a G-tube. You notice he's developing a rash that's hot to touch and has some pus-like discharge. And you go and take his vital signs. When you do, he has a temperature. And as you can see, all the vital signs that you would be taking, these are all components of the score for bedside PEWS. And they're all things that nurses are already assessing. So then when you chart it, this is the way that we're teaching how to do the specific charting. And you get a score of 12. So with that score, you then go to your score match care recommendations. It's greater than 8, so should follow up every 15 minutes in the just to make sure that the child to determine the trajectory. You should have call your physician to discuss and also alert the staff physician to get their input, and then consider continuous monitoring, consider rapid response team, consider transfer, and consider no other patients cared for. However, this also could be a moment in time, and it's all about the trajectory. So you look at them, their score is 12, and in this case, you treat them, you treat their fever, you suction, and everything improves. And with that treatment, you score them again within that 15 minutes, and now the score has gone down to 5. So you can see that it just helps you categorize the patient for what they might need and for sooner review for how to get them the help that they need. Also within that, we're teaching them how to do the G-tube, like how to chart that as well. So this is just very specific for how we're teaching and where you would be able to go and find the details when we're coming as part of, say, a rapid response team. The educational rollout for nurses started on October 16th. We also have champions for all the different wards in the tower, and we've been doing additional training with them. Physicians, other allied health, and also everyone in the PICU. This is part of your educational sessions, but I'm also going to be recording specifically specific scenarios so you can go through them as well and understand exactly how this is working. The planned go live date is around December 10th. But we'll give you the specific date once we have everything finalized. But we will have intensive support, and champions will have t-shirts so everybody can identify them. And I'm going to be available for help as well during that time. So just for the final part for us in PICU, and I apologize with all of the in and out of the internet, I will make sure there's time at the end. I'm just going to finish this part for the PEWS and the PICU response. So sorry, sometimes it can be a little bit corny, but I was like, okay, so we have all these patients that we're looking for. So which ones do we actually need to get on and go help? When I did a brief point scoring for patients in February of this year, I just went around and scored multiple patients, which, by the way, it takes less than 30 seconds to score a patient. And I'm not one who typically charts vital signs, and I was able to do it very quickly and score them now. So, and when we've been teaching, nurses get it very quickly. So it doesn't add to their work load. So if you looked at CH4, the majority of the patients were in the lower range of 3 to 4 and below. And this is, again, just one point in time. The PSU patients baseline would already be higher. And this would just reflect the fact that we know that they're already sicker. They already have higher support needs. And we already know that if small changes can make big differences for them. So this helps us just visualize that. And we also would make specific care plans for those patients. So if you keep getting a score, say their score is always 8, and you've seen that trajectory, well, then you make a specific care plan for them. You don't say you have to keep calling every 15 minutes or doing the vital signs every 15 minutes, but rather once there's a change, then you escalate. So that's where you write a specific care plan for them. So now I'll just go through the ways that it will impact us in the PICU and what we're doing for that. So this is just my diagram again with the afferent and efferent system. In addition to the PEWS teaching, we are reteaching everyone SBAR communication. So that should help with when people are calling for help, just to be very clear and intentional with what their information they're providing. And then I'll go through all the different ways we're looking at things. And then ultimately, again, this culture of safety, we're going to be embedding safety huddles and increasing most responsible physician communication and team communication on the general wards. So the outcome database, so we're going to be looking again, and some of this will be future. I've been also working for the past 7 years on a Canadian PICU database, so that's hopefully coming in the next few years for us, but also continuing to look at things like code blue reviews. I also forgot to mention on here, but RL6s and critical incidents we'll be looking at to kind of capture our mortality trends, our PICU level of care utilization. We're also going to be looking specifically at bedside PEWS, and we're going to be doing audits to make sure it's working well and getting specific feedback on it. And I want to thank also our super users and educators for this. We'll also be doing process measures. So I want to thank specifically Kat Dubeski, Steph Parkin, and Christy Press, who have been helping with the rapid response team. So there's a pretty extensive database that's been created so that we can look at rapid response teams, look at trends, also aim our future education based on the trends that we're seeing and track events. There is now going to be on our rapid response team, or ultimately, we're going to be switching that form to also include bedside PEWS numbers on there too, so that we can capture those as well. And we're also going to, I also will point out that our rapid response teams will increase once we initiate PEWS, because sometimes, whenever you're teaching a large group, there will be some people who think a recommendation means you must call, and that will just be a learning curve. I was at Sick Kids Hospital as a PICU fellow when they launched PEWS, bedside PEWS there. I saw it increase, but I also saw within 6 months or less that it actually improved everything. There was a lot of resistance from the intensive care unit when this was first rolled out at Sick Kids. And then within 6 months, everybody was happy with it. And the amount of rapid response teams actually just kind of leveled out back to a baseline. And then as another balancing measure, the study that I've done with Dr. Nijar, I'll be repeating that 6 months after the bedside PEWS initiation, and then at regular intervals, just to see how our communication is working. So what to expect? So when people call, they will use SBAR communication and add bedside PEWS into the reports that they provide to the PICU. I won't go specifically through SBAR with you today, as I think most of are familiar, but there will be a module on it that you can also follow for your own learning again, sorry. And then we've also been educating and really focusing on the fact that just because there is an RRT doesn't mean they go to PICU. Similarly, just because there's a cold flu doesn't mean there's a PICU. Similarly, if you have a high PEWS scores, it doesn't mean you go to PICU. However, it does help us categorize these patients, follow them up, and get them the care that they need sooner. What can we do as a PICU? So firstly, clear communication with how to follow the trajectory. So we'll work with our groups to have language like, this is what I'm looking for. And if this worsens, please call us back, these kinds of things. To teach, which we're already doing, listen to the concerns and provide a safe space. things like what can make you feel safe for caring for this patient in this situation. These are the reasons they don't need to come to PICU, and reflect, which I always do on HALT, which is, am I hungry, angry, late, or tired? And is that why I am feeling this way about the calls? How can we help support our hospital when we're very busy and communicate clearly from both ends? And sorry, I'll also be looking to our group from the PICU for feedback as well and integrate that. And last points is that the next phases for our hospital will be to integrate, after we launch this, of course, is to integrate this to EPR. So eventually it will all be on the computer. We will have a second extra phases of where scores will be calculated at times of transition, including from the PICU, NICU, PACU, Children's Emerge for when they go to the ward so that it can be trended. But we're not doing this as the first phase. And we'll eventually try to integrate more forms into it, including things like the asthma care map or bronchiolitis. My hope is to also integrate into the child health transport team, because there's lots of data that suggests that it can help us triage our calls, and actually the higher score, or I should say lots of data, at least one paper that has really convincingly shown that the higher scores do correlate with needing interventions at the time of team arrival. So may help us triage our calls. And then also, sorry, I'm just going to move on from that. And then also we're planning to have a provincial spread as well. The provincial leadership wants me to implement this across the province. So this will be kind of a next phase, so that'll be a common language throughout our entire province. And with that, I'll open to questions and discussion. I'll just now close my slides and turn on my camera again so you can see me. Sorry about that. And sorry, I went a bit over just from all the issues with the internet. But okay, just open to any questions. Firstly, okay, your question is still good, Susan. I already saw it, but I don't actually know how many of the deaths are attributed to suicide within that data set. So sorry about that. I can't answer that. But of course, PEWS wouldn't really help in that situation anyhow. But yeah. Okay. Any other questions, comments?
Thank you, Val. That was really good.
Okay. Great. It will be, thank you. It'll definitely be a learning curve. Thank you, Stasa, for everyone. I have seen it implemented and work and really support the teams and their concerns. So I'm looking forward to that, but I'll definitely be interested in everybody's feedback as things change in our hospital. Yeah. Oh, go ahead, Susan.
Sorry, Julie has a question.
Oh yeah, Julie.
I'm not as savvy with Zoom, so I didn't know how to put up my hand. I'm sorry.
No problem.
Just found it now.
Okay, no problem. Go ahead, Julie.
Okay. I'm actually just going to do something with Holly now too, so I might get a lot of these questions answered when I go and chat with her. But I just wrote down a couple things as I was thinking about them throughout your presentation, which was great. Thank you so much. My question would be, with every increased PEWS score, so if I were to have a score the next 4-hour block and it was more than the previous one, am I consulting my CTU every time I have a change of score, or am I just implementing what says on the score sheet, or both?
So it's both. So you are like, if there is an increase again, then yes, it would recommend that you get your primary medical review within that time period, because the idea that your patient is changing in a trajectory that's concerning. If the score is improving, then no, you don't need to escalate that. But the idea would be, it's really that change in score that's one of the more sensitive and helpful parts of it, because the higher, or that trajectory of increase, does correlate with clinical worsening.
Perfect. For, I know you kind of briefly said at the end, as far as like asthma, bronch, those kind of care maps and things. Am I correlating and putting those vital signs on the PEWS score with every one of those times that I'm doing that to also kind of have that escalation? So you're kind of doing the double, right? You're putting it on the PEWS and then also on the care map. So both?
So what we're doing with the care maps is we're putting C, like the stickers that says C PEWS for your vital signs, but then you can still
Okay.
score for your treatment as the broncholytic tool. We do think that the PEWS is going to ultimately show that we don't need the bronchiolitis specific, like the way that tool is now, and we'll eventually maybe change it. But at the bottom in assessments, we're just saying scoring tool to integrate both together, but we don't want them double charting the vital signs.
Okay. Kind of the same thing with the other documentation tools that I was thinking as well. So like things like admission databases and things like that, those are all just moving on to the PEWS score as well. I'd imagine to have like a baseline assessment of where things are at when they get there. For our documentation for like cardiorespiratory monitoring, I know that we had email communication back and forth a bit with Kate and you this morning about how that would look. So for every intervention, is there a space on there? And again, I'll probably, sorry, my ignorance on
That's
that. I'll
okay.
get more when I see Holly.
Yeah.
But I kind of want to assess to see, like, is there a space to put comments on interventions that are being done or
Yes,
during that time frame, or what happened during that? Were they crying? Were they whatever? Like, is there a spot for me
yes.
to be a little more?
Yes, there is a spot at the bottom, and all the sheets that people have been practicing on are not the actual size, unfortunately, just because we couldn't get the full size printed here, because we didn't have the ability to do that, and they're coming from the company. So there actually is more space to write, but there is a spot at the bottom that says intervention and assessment, and then
Okay.
also a way to put like a star that correlates to the notes part on the back. And then if they run out of spot, then they can just write in an IPN that correlates to the date.
Okay, because that's kind of the same thing with all the interventions we do. So if it's a room air trial versus a post-narcotic and whatever it is, morphine, like PPDM thing. So all those things would be the same. So you'd have a star and then somewhere else you'd have a documented piece attached to it.
Yes.
Okay. And then I'm assuming the same thing with our pain flow sheets, because we also document our vital signs on like CI documents, things like that.
Yeah, so the CI record, sorry, that's the continuous infusion. You're gonna put the sticker that says C bedside PEWS, but then you still chart your morphine and all of that because it's considered a MAR right now, a medication administrative record. So we couldn't remove that. But we have reviewed all of the forms in the hospital and have a plan for them. And with time, we're gonna try and integrate even more to get rid of even more of them.
Good stuff.
Yeah.
And then on the one or backside, is there a pain score on there as well to correlate with?
There's a pain score. It's actually on the front, a pain score and sedation score on the front.
Perfect.
Yeah.
I think that's it for now. I need to look at it a little bit more detail. So hoping I get more of that when I get to.
Yeah, no problem. And as I mentioned in the emails, I have been trying to meet with you all as managers. So sorry, I'm glad most of you were on here today. And I'm happy to meet with you again too, because that somehow our schedules have just never caught up. I know you're meeting with Holly now, and then I can meet with you again too.
Okay, thanks, Val.
Of course, thank you. And then Stas, it looked like you had a question too.
Yeah, what is that? Is there a threshold number where an RRT gets called?
Yeah,
or does it depend on too many variables?
So no, there is, but it doesn't say you must call an RRT. It says consider a rapid response team. And that is the score of 7 and above, I believe, but it just says consider. And then it also says if any of the vital signs are in like the red category, it does always say assess need for code blue, but that would be, as we've been teaching, I'm like, if you don't keep acquiring the vital signs, and score them, if you think they need a code blue, just call it code blue. So it's just on there as like extra documentation.
Okay, sounds good.
Yeah. So that's where there will be some, I know in the beginning, there will definitely be more calls, which is never a bad thing if we arrive and they don't need us. It's just going to be a learning process of people's interpretation of what recommendation means, because some people think it means you must call, but it doesn't say that. We've been very clear in our teaching that it's your clinical opinion as well as the score together.
Sounds good.
Yeah.
Oh, and I guess if you go up in score, does that trigger that too? I guess it does, eh? You were
Well,
7.
so so the way it works is like the lower scores don't say that, but the higher score always says consider this. And
Yeah.
if the score is greater than 8, it says consider code blue. The highest score you can get is 26. Usually you don't get that. The ones like, and it doesn't predict what you need. For example, when I was a fellow, I did a review of something like 75 charts of patients who came to the emergency department and scored them. And sometimes their score would be like 26 and they went home, and that's because they came in with anaphylaxis. So it doesn't predict like everything, but in that moment they needed resuscitation for their anaphylaxis. So it's just, in a way, it's similar to like APGAR scores, where it's like it helps you trend in the moment and trend them. And the biggest benefit is the communication from nursing, because a lot of times in every hospital, sometimes nursing concerns get dismissed because it's hard for them to describe how sick a patient is. So one of the benefits of this is that it says the score, like it has to be reviewed with the team, which is a good thing. Yeah.
Sounds good.
Hey, any other input or questions? And thanks so much for everybody attending. Okay. Thank you. Well, it looks like I know we're a bit over time. Thanks for that comment as well, Ravi. And yeah, I'll look forward to the changes and then also all the input. And thanks to everybody who's been involved. Okay. Have a good day, everyone.
Thank you, Val. You too.
Thank you.